Thank you everyone for joining us. We are delighted to have you on board today. Before we begin and before I start introducing our speaker for today, I want to acknowledge the traditional owners of the land upon which all participants of today's webinar stand. For myself, I'm on the lands of the Ngunnawal people, and I want to pay my respects to their elders past, present, and particularly to emerging elders, and to acknowledge the contribution they are playing and will continue to play in the development of their communities and in the development of ours as well. Today we are joined by Adjunct Associate Professor Frank Tracey, Chief Executive of Children's Health Queensland. Frank has more than 30 years experience working in health and systems, primarily in the health system, primarily in Australia and New Zealand. Over his career, Frank has focused on strategies to make the health system more sustainable, to serve the best interests of patients, health professionals and the community in the longer term. I'm really excited about Frank's presentation today. I think the work that's being done out of Children's Health Queensland is innovative, it's exciting, and I hope you'll all get as much out of it as we believe that you will. Welcome, Frank, and I'll now hand over to you.
Hey everyone, thank you Penny. Thank you everyone for setting this up and providing me with the technical assistance that I need to present during the webinar. We're getting the presentation open. I can just reflect on the overarching process for today. So I just wanted to talk with you about what I'm going to be presenting. It's a real privilege to be part of this webinar today, and I'm very excited about the prospect of talking with you all about the importance of population health and a place-based and person-centered approach. We at Children's Health Queensland have been using this approach for approximately 3 years now. And the aim of the webinar today is to talk to you about some of our experiences, what it is that we've done to create the opportunity to work from a population-based health lens, and how we've applied that work to plan services, inform our partners and other providers of the importance of integrated planning across the system, and how we've actually developed a workforce that delivers the right services in the right place at the right time. So that's quite a broad agenda, I'm aware, but I'm hopeful that we can get through that in the time that we have available to us. Can I just start by saying that we have the greatest opportunity of the 21st century to harness data. At no other time in my career in health, and that's been nigh on 40 years now, have I seen an opportunity this great. It's no surprise to anyone on this webinar that we live in a society now that is digitized. And increasingly, if we look at how children and young people are developing in particular, we can see that not only are we living in a society that's digitized, but we are thinking digitally and we're behaving digitally in response to those data and our social context. So the opportunity for us in health and across the system of care is vast. I'm interested in how we can better harness the power of data to make informed decisions about the health and well-being of children and young people in particular. And when we focus on children and young people, we're also talking about the context within which they live, and we're talking about their family and their loved ones and their friends. And for some children, we're talking about their carers, their kinship carers, and a range of other people who are important to them in their lives. Some interesting statistics. I've been doing some thinking and some reading around the use of data globally, and some interesting information coming from the UK, particularly the NHS and the King's Fund, around how data is being used. And one estimate that I read was that up to 30% of the world's stored data is generated in healthcare systems. I found that quite a mind-boggling statistic. up to 30% of the world's stored data is generated in healthcare systems. And if you think about it, if you think about imaging, if you think about phlebotomy, if you think about pathology, if you think about all of those touch points, and in fact, another data point is that every patient who has contact with a healthcare system will have up to 200 data points in that system. So we're rich in data. We're in a very connected world, and we're rich in terms of our opportunity to influence health and well-being. So the approach that we've taken in Queensland and at Children's Health Queensland is a perspective approach. We had done some thinking around how do we harness the power of data and how can we develop a health intelligence capability. And the first step we took was to consider where we sat in the system of care. And my first slide gives you some context to that. So in the state of Queensland, we are the state's lead in pediatric healthcare services. We are a tertiary quaternary hospital, and we run a range of community-based health services across the southeast corner and statewide in Queensland. Those services range from school-based youth health nurses, who by the way are celebrating their 20th anniversary today, and child and youth community health services, as well as programs specifically targeted at specific health conditions, like the Aboriginal and Torres Strait Islander program called Deadly Ears, which is focused on the eradication of middle ear disease. So if I look at the graphic that you have in front of you, you'll see that at the center of everything we do is the family and the children and young people that we serve. We then have a range of hospital and community-based services that intersect and interface with a range of other services across the system. We then, in the next gray circle, look at what I call some of our functions, our enablers in terms of engaging with that cross-sector work. And each of those enablers, particularly the partnership and capacity building, is becoming increasingly important in a sophisticated and networked environment. So if I think about the trends globally, and I'm thinking about how health systems are evolving given the fiscal constraints that we see emerging across economies across the world, we need to be thinking about doing things differently. We need to be thinking about earlier intervention. We need to be thinking about the investment that we're making in health and well-being across a system. And that means that the investment in health and well-being occurs in education, it occurs in general practice, it occurs in social services, not just a purview of health. And I'm interested in leveraging that and utilizing that to improve patient outcomes. So our role as Children's Health Queensland in the Queensland context can be described in three very basic domains. We have a service delivery domain. We have an enablement domain, which means that we work in partnership with a range of other health service providers across the state. So we work with other hospital and health services that deliver pediatric care to their local community. And that's really important because our aim of leading life-changing care for children and young people for a healthier tomorrow means that we need and we must work collaboratively and in partnership with our colleagues, not only across health, but across the rest of the system. The third area is one of advocacy. We work very hard at promoting the health and well-being of children across the state of Queensland, not just through the health system, but also in collaboration with our partners at the Child and Family Commission, the Department of Children, Youth and Women, Education, justice, and other agencies across government. Our commitment as we do this and carry out our 3 core functions and components of our role is we're committed to using data and statistical information to have an evidence base that promotes discussion, informs decisions, and supports the health interface with social services, education, and other sectors. And while we're doing this, we're very cognizant of legislation and the parameters of that, and the importance of compliance with the Privacy Act and other legislative frameworks at a statewide and federal level. I wanted to talk with you a little bit about why a population health perspective is so important, and I wanted to bring you back to the World Health Organization's vocabulary in the year 2000. It seems like so long ago now, and well, yes, it's nigh on 20 years, but at that stage, the World Health Organization were using a vocabulary that described population health as protecting and promoting the health of the population. In the 20 years hence, we're seeing a shift in that vocabulary, and we're seeing that not just from the WHO, but we're seeing it from other jurisdictions. We're seeing that vocabulary change to now embracing the notion of encompassing the determinants of health and well-being, considering issues like town planning, the interface with education, and the interface with social services. So our narrative and our vocabulary is changing, and I've seen that in the Australian context, and particularly in the Queensland context, where our Premier's priorities include an absolute focus on health and well-being, and our government has just set up a health and well-being commission in the state of Queensland. So I'm very excited about that shift in narrative and that shift in emphasis. What that shift does for us is it creates the sense that we have a collective responsibility across many organizations and government departments. That's what integrated care is about, but it's also what a population health lens and perspective is about. The other component of that I think is worth pointing out to you is a population health perspective is an action-oriented perspective. It speaks to earlier intervention. It speaks to going upstream to make those interventions and to make those considerations that have an impact downstream. The language of population health and the language of a population health and a social determinants of health lens is action-oriented. It speaks to collaboration, it speaks to partnership, and it speaks to those partnerships occurring at multiple levels in the organization. When I think about the approaches, and the diagram captures some of it on this slide deck, at the heart of a population health perspective lies this notion of being innovative, being action-oriented, sharing a vision with those in other parts of the system that's not necessarily health, considering how we scaffold that with leadership and good governance, and importantly, creating a culture that is actually focused upstream, thinking about the health and well-being of the broader population that shifts us away from an illness-oriented model. I've spoken previously about this at some international conferences, and I made the comment that developing hospital beds and growing our hospital capacity is not necessarily a bad thing. But think about the pressure that we're putting on that part of the health system. But in fact, there are many more opportunities for us to think and invest in alternatives to hospital-based care. Now, for those of you in the audience who have been working in healthcare for some time, and those of you who are working in other government departments, the NGO sector, and other agencies, this may not be news for you, but it's a really important perspective. We need to think differently. That brings me to some of the detail today, and I want to acknowledge the work of ARACY and Penny's leadership in this respect. We've used the common approach, the ARACY common approach, to guide much of the work that we're doing here at Children's Health Queensland around population health intelligence. And you can, I won't read the slide out, but you can see on the slide the work that ARACY have done with the common approach. And when I saw this work, I was excited about it because for the very first time I saw something articulated that spoke to opportunity, that spoke to how we might think and act differently around the health and well-being of children and young people. So at Children's Health Queensland, we've taken a social determinants of health lens. We're interested in the physical, the mental and emotional well-being of children and young people. And when I think about a population health approach, there are 4 pillars to that from my perspective. These pillars overlap and there are multiple interfaces, but it's consideration of the wider determinants of health and well-being, our behaviors and lifestyles, and the choices we make, an integrated healthcare and education system, and the places where we live, the communities we live in, and we work, play, and learn with. So when we took that lens, we broke that down into 7 key areas. And that was the focus for us when we developed our 10-year Children's Health and Wellbeing Services Plan, which in another language is a clinical services plan. We wanted to reflect children having material basics, being loved and safe, the places where they learned, what it was like to live in Queensland, being healthy, participating in their community, and using health services. I did want to dwell on this slide for a little moment, if you would indulge me, and it is about the issue of equity. Equity, from my perspective, underpins everything that a population health lens is about, because not every child starts from the same position. And I believe, and here at CHQ, we are promoting equity as a core principle when we meet and work with our health partners to help develop a system that can deliver the right care in the right place at the right time, right across the state of Queensland, but also a system that embraces and engages with the other agencies and individuals who play a role in the life of that child living in that community. I'm bringing up each of the data points on this next slide for you. Again, I won't go through these in detail given the time we have available, but I just wanted to make a single point about this slide. We have taken a very clear decision to use the data we have available to us in the system. We used a lot of shoe leather to talk to partners. We had a lot of meetings. There's a lot of data out there. And my view was, let's use the data that's being reported now under our agreements with government, and let's think how we can use that to recalibrate our thinking and the lens that we have around the health and well-being of the population. How can this help inform us rather than a retrospective view? How can it be both retrospective and prospective and future-oriented? The final point I'd make about this slide is find partners. Find partners to work with. Find partners who share your vision. Find partners who are interested and curious about the data. As we think about the use of population health data in a policy planning, practice and research context, this diagram, this very simple diagram for me outlines the importance of a continuous circle of improvement, of evaluation and recalibration. We first need to understand the need to plan for outcomes. We deliver outcomes. We evaluate, we recalibrate, and then we revisit our understanding of the needs. In Queensland, what we've done is at Children's Health Queensland, we've taken these social determinants and we've mapped these into a very sophisticated electronic dashboard that is interactive. On the left-hand side, you can see the data sources. There are up to 35 of them currently, and as of today, in fact, we have 56 data sets that are accessible. These are shared across government agencies, and they have been very generous in providing those to us. We have then mapped those against those social determinants, the 7 that I've described for you, and we've been very intentional about pulling those data sets together to start to tell us a story. And we're very excited recently to have worked with our colleagues in the Department of Education to now start incorporating NAPLAN scores in our data. You'll notice youth justice, you'll notice the voice of the child, you'll notice all of these mapped into that framework that I spoke about earlier that is nested within the ARACY Common Approach and the NEST framework. The next slide really is about bringing this data to life. And I think it's probably worthwhile you spending a little bit of time on this. This is an interactive dashboard, and unfortunately I can't show you the heat maps and pull out the data for you. But this is about the data related to living in Queensland. And we can cut this data across those 53 data sets per SA2. So for those of you who are not familiar with an SA2, that is a population size of between 15 and 30,000. And in Queensland, we have 528 of those. So we were able to cut this data in a variety of ways. We want to make data digestible for decision makers, so the dashboard needs to make sense to the people that we're pulling together. If we look at our statewide data, we can actually track how people are using services. This is really critical for planners and decision makers around investment, and not just in health. We are happy to talk to you more about how we've done this in terms of the detail and how it might help you in your jurisdiction to consider how you can utilize population health data to support your decision making across agencies. The final few pages of the presentation talk to how we've brought this data to life. And I won't dwell on each data point, but when we present this to multiple agencies across government and our partners, they see themselves in this data. This is a data snapshot of the lived life of a girl 0 to 18 years growing up in Queensland. This is her context, this is her lived experience. And these are the social determinants and the factors that impact on her chances of success and her opportunity to be the very best version of herself that she can be, and importantly, to grow up healthy and happy. We are then able to take this data and we're able to apply it to a local area, an SA2 area. So we've used Gympie, which is a suburb just north of Brisbane. You can see that there are 10,350 children living there, 0 to 18 years, and you can see the context in which they're living. How many are living in out-of-home care? How many, for example, live in the lowest 20% of the CIFA data? So what does that say about their housing? What does that say about their ability to afford school trips, their ability to engage? And you can see that their mums, 1 in 4 of them, unfortunately smoke while pregnant. We then get to the data at the bottom of the page where we're now able to work with local health services so they can see how the population, particularly of children, are using their services. So again, this is about bringing together the 56 data sets, thinking about it through a social determinants of health lens, and a population health lens, and creating a narrative that our colleagues, that our partners and our collaborators can engage in to actually start to plan and invest in, importantly, the future of our population and our children and young people. Can I just say that across the state, we are now receiving great engagement from a variety of partners, including across government agencies, the NGO sector, and for example, the Royal Flying Doctors, local councils, and those who are interested in how their community can thrive and advance, and how they can create a context and an environment for their children to succeed. I'm aware that time has caught up on me, and that, as you can tell, I'm passionate about this area of work. I'm very happy to take questions from those who have joined in the webinar. We have much more context for this work. This is a snapshot only, but can I just emphasize in closing the importance of using cross-agency data through a social determinants of health lens to inform what it is we do and what our expectations are in relation to improving the outcomes for children, young people, and their families. And this stretches beyond health. This stretches to the very core of what makes our communities the beautiful places that they are for children to grow up in. Can I say finally, thank you so much for your attention and for engaging with me over the course of this webinar. It's been a very pleasurable experience, and I wanted to thank the ARACY team who have assisted me greatly over the past couple of weeks to pull this together technically and to be able to share my message with you more widely. So thank you.
So Frank, thank you very much on behalf of ARACY and everyone who's tuned in. Not sure whether we've got questions rolling in yet, but there is a few moments that people get some questions in that we can put to Frank. But in the meantime, I guess just on behalf of ARACY, I'd just like to say how great it is to see the nest being used in this way. You talked about building partnerships and shared understandings and getting everyone pulling in the same direction effectively for the benefit of children. And that's exactly what we designed the nest to do. And it's so great to see it being used in this way by the Queensland government and your team in particular, your department in particular, Frank. So that is just fantastic. Thank you. Have we got?
Yeah, my response to that, thank you very much. I was excited when I saw the NEST framework because for me, for the very first time, what it did was it brought some of that thinking to life in a very visceral way, and it gave a structure and a framework that allowed us to build a narrative. We were then able to springboard off that work to do the work that we're doing, and I'm hopeful that the work that we're doing can now provide a springboard for others to deepen that, have another layer of sophistication to it, and start to think about how this work can influence not only service provision, but as I've mentioned, investment and policy. And of course, the research elements for this are also obvious. We have a huge opportunity to really deepen our understanding of what works for the population. What are those factors that we now have the evidence for that can be successful, and what can we invest in more of? And I mentioned earlier this notion of the hospital versus the community, and I think it's an outdated notion. I see us all as part of the one system, and we need to think about an and rather than an either or. And I think we're well positioned to do that, and if we use the data that we have available to us in a creative way, and you'll notice behind me that one of our Children's Health Queensland values is imagination, and what I've said to my team is that I'm asking my team to use their imagination to think differently about the myriad of data that we have available to us and how we can bring that to people in a condensed way, in a way that makes sense and allows decision makers to involve themselves in a really robust conversation that includes co-design, that includes green spaces. In Queensland, we're working with the Cross River Rail, we're working with education, and we're really thinking hard about how do we create the environment that will contribute to success. So the ARACY work has really been a fundamental pillar of that.
Thank you, Frank. We're getting now. I'll just read them. I hope you can hear me okay. We've got a bit of a feedback loop happening. We're not sure what's going on there, so apologies for that. Some of the questions are actually going to data in the first instance. One is the databases you've been designing and building, what's the ability to share those across Queensland? And I'd also extend that to, and you talked about helping other jurisdictions earlier, are you getting any interest from other jurisdictions or the Commonwealth in maybe being able to access your data and build some sort of national database from that? Is that a possibility?
Yes, we are. I think the context here in Queensland has changed in the past 3 to 4 years. As I mentioned, our government and our Premier and our Minister for Health are very interested in doing things differently, not because they want to just simply do things differently, because they're actually committed to working in a different way and investing in health and well-being in a different way. And government agencies have been very generous with us in terms of sharing the data. Hospitals and health services have been very generous because for them it's important to know who's using their services, why they're using their services, and where they're coming from to use the services. So at a statewide level, we're thinking globally and we're acting locally.
Thanks, Frank. Another one, and they're moving around very quickly. Can we filter the data by other social determinants of health, for example, culture, LGBTIQ, and disability?
Yes, I think that's a prospect for us, and I think that that's the next level of sophistication. When I asked this community who have joined the webinar about their aspirations, I'm putting a challenge out there to everyone who's involved in this webinar and listening to this narrative. I'm saying, come speak with us, go speak locally, talk to people who make decisions in your jurisdiction. Let's think about starting with building a solid foundation, and then this layer of sophistication comes with experience, comes with people engaging in the data, and it comes with it a challenge. And the challenge is that let's be careful about what it is that we're saying, because the data doesn't give us all the answers. What the data does do through a population health lens is enables us to ask the right questions, and that's different. So in answer to the question about should all the data sets be introduced, of course they should. I think that will help fundamentally with decision making and in guiding policy. I think the introduction of those needs some careful thought, and it's about the when and the how, not if.
Frank, I think you might have just partly answered this next one, but I'm just going to ask the question again anyway for completeness. Has the work to date given you any clear indications in terms of the efficacy of current planning approaches and resource distribution? E.g., what is it saying about access to allied health services in the community? And we're also getting, sorry Frank, we're also getting some particular regional bents to a similar kind of question around that.
Yeah, look, I think it's been very instructive, as I have repeated previously. I think when we present that archetype of that young girl growing up in Queensland or growing up in a particular SA2 area, it speaks to multiple agencies about their engagement, their service delivery, and the investment. I think then the next step, and what we've used it for example, at Children's Health Queensland, is we've used it to redesign where we deliver services and the skill mix that's required to deliver those services locally. So we have used it to plan services like a co-located service in Yarrabilba, which is a community south of Brisbane, a new planned community with an infrastructure that's developing, but with need there. We've used it to plan how we work with schools in a different way, how we deliver child health, child development, and child and youth mental health services. So where the need is, where the population focus should be, so where people are living, we think about equity, access, all of those, and use the data to inform our thinking and planning around those. And then to workforce, we've used that service design to work with our workforce to determine what's the most appropriate skill mix, including nursing, allied health, or pediatric specialists that we require to deliver that nuanced, right service to that community. And that means that we then have to engage with the community in a different way about determining what it is that they believe they need. So that co-design, that human-centered design, all feeds into this notion that you need an interprofessional approach to work in this way. And if you're looking at your data and you're thinking about patient need, and if you're thinking about the required outcomes, well then your skill mix and your mix of allied health, nursing and others becomes something that is intentional rather than replacing like for like. So I think working from a population health perspective and using the data has a great opportunity for us to rethink our workforce, how we train, how we support, and how we develop leaders to lead services differently into the future.
Thanks, Frank. We've got actually a load of questions coming in, and we're trying to, any we don't get to, if I could just point out, we'll send to Frank and he'll be able to answer them on notice, and we'll put the answers up on our web page with the recording of this webinar. But we've got one here that's a question about, are there any future data sets that you might envisage integrating and utilising in the future? So I think the question really goes to, do you know what you're missing and what you'd like to have included?
I think it's always seductive and tempting to say that we've got the full picture. The reality is that we don't. We started with those social determinants, and we looked in a very intentional way around the data sets that we believed we needed to help us address the questions that patients and families were asking of us, to help us address the questions around where services should be located, and as I've said, the skill mix. We've grown that data set over the course of 18 months from 35 initially, well, obviously it started with 1, but with 35 initially now to 53 in this year, and that's about bringing on the Department of Justice, the police, the Department of Children, Youth and Women, the Child and Family Commission are sharing their data with us now. So I think as we go on this journey, when we engage with these data and we talk about and ask questions of it and pose those questions for ourselves, I think then inevitably it will be organic, and we should build in a discipline into the system that prevents us from going down the pathway that we have previously, where you include everything, but actually the intelligence isn't there. You're unable to cut it in a meaningful way. It's not linked to anything, and you lose the opportunity for people to engage with the data. So we have to strike a balance, in my view, but I do think that it's iterative. And I do think that there will be, and certainly are, other data sets that we should and must include. I think to a certain extent, our partner agencies will determine that.
Thank you, Frank. We've got another one that goes to national policy question. I'm cheekily going to ask it of you. I hope that's okay. What are your thoughts on the Every Child campaign and the push to establish a National Child Development Fund and national wellbeing indicators? ARACY would love national wellbeing indicators. I might just put that out there. How do you see the work you've contributed so far linking in with this? Do you think there's an opportunity for that nationally?
Look, I'm delighted that the narrative has shifted. I'm delighted, as I mentioned in the webinar, if I think about our narrative and our vocabulary from the World Health Organization 19 years ago or 20 years ago now, we've shifted. We're constantly growing, we're constantly developing our understanding, and we're broadening that. So I think for Australia, we're in a fantastic position to do something that will enable and support each state to do a piece of work that is specific to that state, that is nuanced enough to deliver improved outcomes in that state, but actually works within a national framework. And I think you need to look no further than the influence of the common approach in the NEST framework to say that there is success to be had and there is guidance to be had from those national frameworks. And if I can use a current example, here in Queensland, we're working with our colleagues in the Department of Health to now start to look at a framework for adolescent health. What should that look like? What must that look like for that section of the population that we haven't really focused on as a cohort? We have specialist services that are delivered to adolescents, but there's an absence of a framework. So what I'm saying in a rather roundabout way is that yes, yes, and yes. We should always be looking at frameworks that can guide and support us and contain us in our thinking, and that move us to thinking in creative ways around how we can act locally. And again, I use that phrase that I used previously. If we think globally and act locally, I think we can all be proud of the work that we do here in Australia. And I think we can learn from each of the states and territories. There's some, as I travel around this country, there's some amazing work that's being done in Victoria, New South Wales, in the Northern Territory, in Western Australia, Tasmania. I can just keep going on. It will be great to get people together to look at how we can share the best of that in a networked way, and how we can enable and support that work to be done locally to make a real difference for those communities.
Well, Frank, if your counterparts in the other jurisdictions are as keen as you are, I think we're in good shape. Now, we've had a question. It goes to access to the data. I think this might be a government employee, and they're just asking a really great question, that if I'm working in a government department, is there an option for me, is there an ability for me to be able to get into the data sets that you've built to explore the area around me? I'm just not sure how you're going with making that available, or whether there's a plan to do that.
As I mentioned, we're really conscious of the laws and the regulation that controls and necessarily controls the use of data. So we're very happy to, certainly within the Queensland context, to talk with our colleagues across government about how they can interact with the work that we are doing. As you know, each government department in every jurisdiction has their own style and approach to formulating their data and sharing that data. So if it's a specific government employee, I ask them first to go through their department and determine how they're utilizing their current reporting data from the system, whether that's been fed into our repository, and then of course we would welcome their engagement with us at an individual and at a group level, because I think the more we can share the thinking around this, the better we'll be placed to inform thinking and inform decision making. And I think that that goes across all levels of government. It also goes to each person who works within the system, because to my mind, everyone who's involved in either collecting these data, in analyzing these data, and interpreting this and pulling it together has a role to play in the bigger system and how we apply that to improving health outcomes. So yes, welcome the connection and engagement.
Thanks, Frank. We've got a question here. It asks about your frustration. So I'm going to reimagine the question, and that is the questioner says there's mountains of data being developed, and I guess I'll ask it in the positive. Do you see it being, or are you confident that it's making the data and the use thereof and the planning therefrom is having an impact on the social determinants of health? And I think this probably goes to your NEST approach, but I'll let you answer that.
Unreservedly, yes. At a local level, we are seeing the change, and I am confident about that because parents and children tell me that. So service users tell me that when I talk with families and when I see some of the unsolicited feedback that we have from our services and from parents and children who engage with services, they tell me that. My staff tell me that they see a difference. They see a difference in their engagement in work, and they see a difference in terms of the services that they're delivering and new opportunities for them. So overwhelmingly, I can see that there is a positive aspect to the way that we're working here. Is it challenging? Is it frustrating? Yes, of course. When I first started to think about this and develop this particular approach, it is frustrating. When you establish a vision and when you want to bring others with you on that journey, you have to look out for friends. You have to look out for people who want to work with you, who want to partner with you. But I'm really pleased to say that there are more people in the system who value this way of working than there are who don't, and it is completely complementary. I've had our senior medical colleagues in surgery, in intensive care, in emergency department, really interested in what the factors are for the families that they're engaging with and the patients that they're engaging with, what those factors are for them, because when the episode of care is complete, they return home, and the impact that that environment can have on that child or young person is significant. So our clinicians are interested in this work, not just those who are delivering services in the community, but those who are also in hospital setting. I am quietly confident, but completely relentless about the importance of thinking this way, and importantly, behaving in this way so that we actually start to align our actions with our narrative, think differently about the system, and listen to the feedback that families provide us and that our partners across the system provide us. So that co-design piece, that human-centered design, all of those principles and models sit behind all of this. But circling back to the original question, does it work? Yes. Do we have examples? Yes. Could it be better? Yes. Will it be better? Yes. But that depends on how hard we work and how much we're prepared to use our imagination to think differently.
Frank, thanks very much. I think we've covered all the questions. I've tried to group them because some of them double up. So we've done our best to answer all the questions. If there's anything that comes in, we'll pass those on to you, or indeed, I think many of the people watching this are part of your show and may contact you directly. But Frank, can I just say again, thank you for the presentation. We've had a lot of positive comments just in the questions about the quality of your presentation, and I think the enthusiasm you bring to it. So thank you very much, Frank. Just a bit of housekeeping.
To those who have joined in and listened in, thank you for taking the time out of your busy day. For those of you who are interested, please reach out and contact us here at Children's Health Queensland. We're very happy to have a conversation with you or host a visit if that's possible. I just wanted to point out to the audience, there's an opportunity coming up to hear more about this work at the Australasian Asia Pacific Integrated Care Conference in Melbourne. That conference is on from the 11th to the 13th of November. And for those of you who haven't looked online, have a look at the International Federation for Integrated Care website, the IFIC website. Have a look at that. We have at Children's Health Queensland, we've stood up a special interest group around child and youth and family-centred care. That group is co-chaired by Dr. John Eastwood from Sydney and myself, and we have a host of wonderful people who are interested in spreading not just this knowledge, but the knowledge around the health and well-being of children and young people and families much more broadly. So pop on there, look at the Integrated Care website. I encourage people to look at the King's Fund website. There's some fantastic articles in there around the work that they're doing in the UK, and the King's Fund take a systemic perspective. Thank you all very much for joining in, and I look forward to your questions or to our conversations. And once again, to Penny and the team at ARACY, we're absolutely delighted to be working in partnership with you, and I look forward to how we can bring this conversation and this agenda more nationally.
Many thanks, Frank, and thanks to everyone who attended. This webinar, or recording of it, will be available soon for our financial members. Our next webinar will feature ARACY Research Manager Lauren Renshaw. Lauren will talk us through the development of her new paper on measuring the impact of identity and culture on the wellbeing of children. Lauren will also discuss how we can use these indicators to design better policy and programs for all kids. And that webinar is on the 1st of October. Frank, once more, thank you very much, and thank you to everyone who attended. Have a good day, everyone. Thank you.